Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be sitting here today with an entrepreneur extraordinaire. Just heard the quick rundown, and I cannot wait to kind of dig into all the many experiences that you have had. Eric Lisle is the CEO of Southeast Primary Care Partners, building out a really interesting kind of middle ground model for independent docs, it sounds like. Eric, thanks so much for joining today.
Yeah, I'm happy to be here. Thanks, Mendel. Appreciate being on the podcast.
Talk to me a little bit about your time in the military and how you decided to get involved in healthcare.
Yeah. So I joined the military pretty much right out of college. I was a medical supply technician in the Air Force for a while before becoming a medical service corps officer, which led hospitals and did administrative things for hospitals, culminating in being the administrator for the NATO Trauma Center in Iraq back in 2006. And then I left the military from there. But my entire time in the Air Force was healthcare. So I started out as a healthcare supply specialist. I ended up as a administrator running hospitals, which is what led me into my next career, which was at Humana, where I started out as an analyst in the TRICARE business. And I ended up running TRICARE for Humana for a number of years.
It's wild.
Which is the military health program.
In the military itself, why'd you choose to go the healthcare route and not another one of?
Yeah, actually, initially, I always thought that I might become a doctor. It was kind of my path. So I wanted to get into healthcare, figure some things out, and then go back to medical school. Decided to stay the administrator route. I kind of liked it, and that's where it stuck. In fact, when I came back from Iraq, my kids, I was the administrator leading the trauma center there, the NATO Trauma Center. I came back from Iraq, and my kids would say, Dad, you're just a doctor's assistant. And it's kind of stuck, right? Which is what I've done ever since. I've just been facilitating doctors, doing a good job for their patients, helping them support them as best I can, which leads to where I am today. And we'll get into that here in a minute. But that's kind of the focus of what I do, is supporting doctors and doing what they do best.
Got it. So you may or may not be able to speak about this, but I have to ask. So military industrial complex, how does it affect when you were doing supplies in healthcare for the military? Is it as horrible as YouTube makes it sound? Are you guys getting in Band-Aids for $100,000 a piece?
That's pretty interesting. Yeah, that's really interesting. The first couple of years of my career in the military, that's what I was doing, was sitting in big warehouses, overseeing war reserve supplies, right? So you'd have all these war reserve materials there in case of World War III. You'd have all these supplies pre-programmed, laying out in the front lines, ready to go. And it wasn't quite as bad as that, right? So I don't remember spending $100,000 for a toilet seat. But occasionally, you'd get stuff that was you made you scratch your head as to why you're paying so much. Generally speaking, though, I think the supply system in the military, at least on the healthcare side, was pretty well run. You can't speak to the jets, and things like that. I mean, the $50 million jets and things. I don't know how those are run, but that was my level of expertise. But I felt like it was pretty good. And then one of the things I did post-military is I went to the National Defense University. I sat on the board there for a while, but I went to something called the Industrial College of at the time it was the ICAF, Industrial College of the Armed Forces. It since became the Eisenhower School of Military Studies, based out of DC. And that's a lot of what they focus on, is exactly what you're talking about, is like making sure that the complex is controlled and, things are running smoothly and things are being the citizens are getting the value for the dollar that they spend. So I spend a lot of time in that space. Yeah,
it's wild to see those. I don't know if you get these as well, but like these videos on YouTube where it'll show like a gun on a warship going off, and it's like they open it, it's like $1, then $457,000.
Yeah, no, it's funny. There were when I was in Iraq, I mean, there were contractors that were over there. It seems like we're paying a lot of money for these porta potty cleanings, and there's like a lot of weird stuff going on from time to time. And we didn't always make the best decisions. So we'd spend millions and millions of dollars to create. I remember we spent millions of dollars to create a hardened facility to take care of patients. Where I was stationed in Balad, a year and a half later, handed it over. Right, so all that money that was spent on this hardened facility got handed over to the Iraqis just a couple of years later. So there wasn't a lot of. Sometimes there wasn't a lot of forethought put into the money that was being spent for the longevity that you're going to get out of it. From my perspective now,
Yeah.
I'm sure there are reasons.
I mean, the government's the ultimate, corporation. It's wild. I mean, massive corporations have. I was walking through a massive health system 2 weeks ago, and with the CEO, and I'm walking through their cafeteria, and it's like gorgeous, huge cafeteria, and I look at the person next to me, and I'm like, it's got to be so nice to have budgets, where it's just like it's just a matter of putting a check next to this or that, you know what I mean? Like there's no, and so that for the military, I mean, it's just next level, right?
Well, I mean, so there's benefits to it, but there's also like I always tell a story about the one time there was an example of a 4-star general who was sending out a Christmas email to the troops saying, "Hey, Merry Christmas! We love what you're doing." There were 47 touch points for that email. Like 47 people had to approve this email before it went out, and it was just a generic email saying, "Hey, Merry Christmas! We love what you're doing. The citizens support you." Blah blah blah, and it's hours and hours of time and thousands of dollars went into the administrative work behind supporting when that email sent out. So there's value, but then there's also the bureaucracy creates a lot of headaches and a lot of cost.
Yeah. Anyway, so after the military, you've got this wild history. You were at Humana, Highmark, Centene, Optum, and each, pretty high up their position.
Yeah.
What's the highlight reel? And
so going into Humana from the military was a pretty easy stepping stone into commercial civilian life, because I focused on the VA healthcare and the military healthcare under the TRICARE program. So I went in there as an analyst. I ended up leaving there running the TRICARE program for Highmark or for Humana as chief operating officer. I then went from Humana. I decided to step out and try something besides military healthcare, although this was civilian supporting a military contract. That's when I went to Highmark to say, okay, let me go try this and see what it's like being in the civilian world and understanding what's going on from a different perspective. So I went there to be the customer officer, running customer operations and driving customer strategies, trying to align sort of the health plan with the hospital system that they had just acquired, the Allegheny Health Network hospital system that they had recently acquired and were losing a couple $100 million on. So we're trying to figure out how to get patients matched up with the health system to try to drive value in both. And that was an interesting 3 years. From there, I went to Centene, where I helped stand up the health plan in Pennsylvania. It was a long-term care plan, about a $5 billion company there, mostly long-term care, really expensive patients that are really costly that you're trying to save money on from a capitated perspective. Also a little bit of Medicaid and Medicare in that world. And I got recruited to come down to Optum to lead development for WellMed, which is the largest subdivision within Optum Care, and set up clinically integrated networks, ACOs, and did several, high dollar acquisitions, dozens of small ones, several big dollar acquisitions during the time that I was there for 3 years, which leads me to where I am today. So I'd done that for 3 years. It kind of, if you think about the evolution of my thinking, I was in the hospital systems in the military, understanding what it's like to be in the hospital space. I went from there to run sort of the insurance for the military, and then from there to lead the customer efforts for Highmark, then run another insurance program, and then went to WellMed to where and Optum, where I picked up a lot of thinking around how do you engage with physicians. One of the things I picked up in Centene, I think, which was really, and at Highmark, is it's really difficult for a payer or an insurance company to drive physician behavior. It just doesn't work, right? You can incentivize them, you can push them, you can provide data in front of them, all that kind of thing. But if the physicians aren't aligned with those incentives in a really meaningful way, then they're not going to behave in the way you'd like them to. And so you struggle trying to get physician behavior to change, which is why Optum, in my view, it's just why Optum created the strategy of let's go bring them on as a part of us, right? So let's create this Optum Care organization. Let's start bringing providers into the mix, making them key players in the whole system, right? Particularly primary care providers. And we can talk more about that. But bring primary care providers in particular into the system. They've got management of the patients. The capitation for those patients runs through them. They get to control sort of where they get referred to, how the costs are associated with them, keeping them out of high dollar systems and keeping them in independent, low dollar sort of ancillary services, things like that. So I learned a lot throughout the entire journey, right? That got me to the point where I was at Optum, and it was a great model that they were deploying. I loved what we were doing. concept behind it was similar to what I'm doing here, in that get providers aligned, get physicians aligned with the strategy. And if you incentivize them with the strategy itself, then the whole system's going to perform better. And I think what caused me to say, okay, I'm ready to move on to try something else was, there's a lot of doctors that didn't want to be a part of a giant system like that. They wanted to maintain their autonomy, maintain independence, have the ability to practice medicine the way they believe that they should, as opposed to being kind of dictated to from a larger enterprise around, here's the way we need you to practice. Here are the conditions you need to look for. Like, here are all the things that we're going to require you to do as an employee of this large group, which just didn't feel right to some of the patients or some of the doctors. And the satisfaction wasn't as good as I would have liked it to have been. So we'd bring them into our system. They weren't all that excited about it once they got in. And the way that we were asking them to practice wasn't always aligned with the way they wanted to practice. And so I saw a need out there and a gap to fill, particularly in certain markets of the country where value-based care hadn't evolved really in a meaningful way. And also physicians hadn't gotten together to form relationships with each other so that they could have a little bit of leverage, not leverage is the wrong word, but a little bit of power within the system to be able to say to the payers and to the hospital systems, pay attention to us, right? Don't treat us like second-class citizens, but treat us with the value and respect that we deserve, because we provide all the value for the system. And so that's what led me to come do this, and that's kind of where we are today.
Wild, yeah. I actually know more than you might think. One of my first clients 5 years ago, brilliant guy, and he built up a practice to like 6 or 7 locations, maybe 10, maybe over 10 locations, and then sold to WellMed. So I was actually intimately part of that transition. And I have
depending on how long ago that was, I might have been a part of that, right?
Might have been you.
Yeah.
About 4 years ago.
Yeah, very well could have been. I left there 3.5 years ago. So what was his?
We'll have to trade notes.
What was his geography? Where was he located?
Houston.
Oh, yeah, it's very possible. Very, very possible. He was in Houston.
We'll have to trade notes, because I actually have a whole long story about it, because we were doing all these CCM services for them, and their patients loved it, and it was really great. And when WellMed did the acquisition, they looked through all their vendors, and they nixed like 97% of the vendors, but they kept us and one. They were like, these guys are doing good work, we want to keep them. But then they didn't allow us access. They moved everyone over from their EHR to
Clinical Works.
To ECW. Yeah, exactly. And then they didn't let us get access. But no, it was worse, because they didn't not let us get access. They just didn't give us access. And then no one was willing to make the decision about either just cutting us loose or giving us access. So we ran around in circles. So I was like, I cannot in good faith continue to service your patients if I don't have live access to your EHR. And so we ended up in that mix, I ended up getting in touch with the founder of WellMed. What's his name? Dr.
Rapier.
Dr. Rapier. I got in touch with Rapier, and I was like, do something with your organization, because this is crazy. And he sent a letter out, and it was a wild story. I ended up sitting on a plane next to this guy, Henry Cisneros, who is the mayor of San Antonio. Yeah. And then he connected me with it. Was a wild story. It was a good story.
That's interesting. Yeah, we do have that's a beer story, right? That'd be interesting to talk about.
Yeah, we should definitely talk about that.
You're from San Antonio. That's where I came from. So.
Oh, that's hilarious. Yes, I love Henry. I mean, great guy, and I'll catch you up on all the details after. But that's really funny. So anyway, you must have learned a ton about some of the, and you started describing some of these things about some of the gaps in the industry, and so that's why you wanted to start this Southeast. Yeah. So what's kind of the premise for, and how is it different?
So here's what it's a couple of things. Like, one is, when I left WellMed and Optum, there were only a handful of, as you can imagine, there's only a handful of places where you could go that would be outside of a non-compete for a company like that, right? So I had to think about that. And so the Southeast in particular, outside of Florida, was a place where Optum didn't have a presence yet, right? They hadn't moved into this space. Secondarily, in the Southeast, there's not a lot of aggregation of physicians, as I talked about, like where they're pulling together to try to create entities where they have the power to talk to negotiate contracts with payers, to talk to health systems, that kind of thing. So that didn't exist. And the value-based movement, whereas in, Florida, highly maximized in terms of value-based. California, New Jersey, Texas, and other places, they're really highly maximized in value-based, meaning that their MLRs are in the 50s and 60 or low 60s, and their risk adjustment scores are in the 1.4, 1.5, 1.6 range. In Georgia, in particular, in most of the surrounding states, we're talking sub 1 risk adjustment scores, which means the conditions had not been identified. So it wasn't like the patients in Georgia are any less sick than they are in Florida, whether it's a 1.5. It's that they haven't identified those conditions. And so as a result, there's a lot of upside related to identifying the conditions, getting paid the premium that you deserve based on the sickness of the patients, and then driving costs down once you identify what those conditions are, putting in place programs that are going to allow you to drive costs down. And so the ability to come into this space, Georgia, Alabama, South Carolina, Tennessee, Southern Virginia, like those kind of places where that didn't exist, there's just a lot of upside to be able to support the physicians in a way that's going to drive things in a really positive direction for them. So when we came in, it all became about the independent practice, right? We wanted to figure out a way that we're not going to come in and tell independent practices that we're going to change the way you practice. What we're going to do is come in and say, we're going to bring you support and services and contracts and, value-based opportunities that didn't exist before, that you couldn't do on your own, that if you join this larger group, you're able to accelerate your journey to doing more. And when we would go out there and talk to physicians in the communities that we're in, many of them had inklings and thoughts around joining together and doing things together. But it's hard, as you know, right? You've been in that space. It's difficult. You can't do a full-time job as a physician typically and start joining up and becoming an entity. There's there's interpersonal things that go on, but there's more importantly, you just don't have the bandwidth to do that. And so a group like ours that can come in and say, hey, let's do this together, it's a meaningful thing. And we found there's a lot of interest in making that happen. More than I ever believed possible, right? I mean, there's so much interest in people wanting to join our group, way more than we have the capacity to bring on. So we're bringing them on as fast as we can. But, from an integrations perspective and a financial perspective, it just sometimes it's slower than we could. We could potentially be 1,000 employed providers right now if we had the wherewithal to be able to deliver all that at once. But it's just, we're going as fast as we can. Yeah. Yeah.
I had another question for you, but I actually want to dig into this for a sec because I'm kind of going through something similar. Isn't it painful? Isn't it painful when like you see the future and it could be here, but life just has to catch up and there's nothing that you could do to press that gas pedal harder? I mean, what's that like for you?
Oh, it's for somebody like me, it sounds like you, it is very painful. Like I've got a list of things on my board. Here's the 17 opportunities I want to take advantage of. Like, here's all these things I want to do. And I can't do them, right? I just can't. I got to do what I'm doing, right? I got to get that tight and right and make it work before I can step into the next space. Because in the world that we live in the primary care space that I'm in, all of my doctors are primary care, so I don't have any specialty. But in that space, there's so many adjacencies that you can begin to step into. Like I could create specialty clinics today where I'm hiring specialists and I could fill them up with my own patients, right? And they'd automatically have full panels. And we'd be making money and saving money and everything. It's just I don't have the bandwidth to do all that. I could double my size just by adding specialists. And there's like infinite number of things that we could do. Employer group, contracting, like it's limitless, right? So it's hard sometimes to, put those aside, say, let's talk about those next year and focus on what we need to do to get done today, right? I agree completely.
Yeah. I think one of the lines I've repeated at this point a couple times on this podcast, but the former CEO of Kaiser, Dr. Robert Pearl. So he's been on the podcast a couple of times, and last time we were talking offline, and he said a really good line to me, and it's helpful, I think, for seemingly our personality types, which is, keep your vision wide, but keep your focus super narrow, and that's the balance that you really have to strike with. Like, okay, here's the whiteboard, and then, all right, what's the next step? It's like, it's so hard, but I think of my brain as like a pinball machine where it's just like bing, and then it's like, all right, all over, but then, okay, what's the next? Where's the ball bounced though?
Yeah, when it gets to the powder, you got to hit it, right? You got to hit it.
Yeah, exactly. That's the other side of it. So, but coming back to kind of the value prop here, I mean, it's obviously a huge issue. Doctors, look, 90% of doctors are not business people. The ones that are both doctors and business people end up, kind of becoming unicorns, typically speaking. Yeah. But for that 90%,
Dr. Pierre is one of them.
Dr. Pierre is one of them. Yeah, Dr. George Pierre, what a guy. And is he still off in Europe or Italy or whatever?
To my knowledge, he is. I was just talking to somebody who was talking about him a couple of days ago. Yeah, he's out running around doing his thing, right? So he has his big estate in Italy.
Right. So, but for the 90%, they went to school to learn how to care for patients. And then they are like, all right, well, let me go start a practice. And then next thing you know, they're hit with, oh, you got to hire people and you need EHRs and you need tech and you need IT and you need security and you need insurances and you need HR. And, there's like all these things to running a business. And then they find themselves just in this rat race of trying to keep the lights on instead of actually enjoying what they do. And so the answer to that is, okay, well, go get bought by WellMed or go get bought by a system. But then they find themselves equally unhappy because now they're just a name on a schedule. They don't see their patients. They're just in another rat race. They jump from one rat race to another. And so there's a couple people that I think are doing a good job with trying to solve that middle ground where how do we back the docs and take care of the parts that they don't want to do, but also give them that feeling of autonomy and that kind of, that feeling of satisfaction about their work. Right.
Yeah.
So what are some of those things that you guys do take on that you think are value adds to the doc from a?
Yeah, I mean, that's exactly what we do, right? So we take on all the HR administrative burdens. We take on the financial burdens related to leasing. If they own the building, we'll lease their building from them as a part of the SPCP enterprise. We actually, one of the things I think we do that's unique is when I go talk to these doctors, what I tell them is, you're not losing, you're not going to stop being an owner, because you're conveying ownership in your practice into the larger group, right? So now you're part of a collection of a larger group. So most of the physicians that become a part of our group also have ownership in SPCP. So it's an entity that's designed to get everybody aligned around what our strategy is, and we're focused together on doing that. We have semi-annual ownership meetings where we sit down together, go over the financials, help everybody understand where we are and where we're growing. And I think that's been really helpful to the group, getting physicians aligned with us. And then we take on, the technology headaches, billing, accounting, all that kind of stuff, just the regular day-to-day mundane things that they don't like to do. We try to take all that off their plate so that they can focus on doing the things that they do like to do and they went to school to do and they really want to do, which is practice at the highest level they're trained to do. And so rather than being, the person who's sweeping the floors at night to try to get ready for the next day, which a lot of times, the doctor or his or her spouse, they're the ones that are doing all of that stuff, right? So when that goes away, it's funny. A lot of times the person who's most excited about the deal is not the physician, it's their spouse.
Yeah. Who's usually also the office administrator.
That's right. They're the administrator. They're the bookkeeper. They're the ones that clean the building. They're the ones that call the patients back. Like they do everything, right? They're sitting there at the table saying, yes, we're doing this. Yes, we're going to do this. And they're looking at their husband or their wife and saying, yeah, this is happening. Because they want to get rid of all that burden that's on them as well. So it becomes almost a no-brainer situation for these guys to want to do this because they're not losing much. And, whereas when I was at WellMed and Optum, our NPS scores, I don't want to speak anything but they weren't that great. I'll just say that I'm not going to speak specific scores, but our NPS scores
would be something practitioner satisfaction. What?
Yeah. Net promoter score, which meaning, are they happy with where they are, and are they willing to promote you to a friend, right? That's what that kind of stands for. And the scores at Optum were not that great for the physicians. The scores in our group are in the 80s, which is Disney level NPS scores. So the physicians like being a part of our group. And so when I go talk to a new physician, I was just in Greenville talking to a handful of them, 6 practices they were interested in joining. I give them a list of every physician that we have and say, call any of them. Like I don't sugarcoat, I don't cherry pick docs that are on my team and say, hey, talk to this guy because he's going to be good for us. I say, call anybody, right? Because I think for the most part, our physicians like being a part of our group and they're happy with it. And if they don't, I need to hear about it. And, we consider ourselves, we've got a chief physician experience officer. We consider ourselves all physician liaisons and physician assistants. And that's kind of the focus of our organization. And so making sure that they feel good about what they're doing and that they feel like they made a good decision joining us is really important to me and to our team.
Yep. Yeah, that's awesome. And I guess is there cohesion from a branding perspective? Do people kind of come under the general umbrella, or do they keep their?
They do. So kind of. So what we do is, we think it's important, and I think they do too. It's important. Some of them have been around for 30, 40 years, or even 60 years if they have a legacy of their father or mother. So their brand has been around for a long time. We want to maintain the strength of that brand in those communities because we have a lot of rural communities that we're in. And so we'll go in and we'll say, okay, you can stay XYZ brand. We'd love for you to do that. We want to support that. We'll market under that brand. But you're also part of the Southeast Primary Care Partners group. So we have double branding in those spaces. A few of them will say, hey, look, can we just move over to your brand? That's fine. Then we become Southeast Medical Group. But generally speaking, they keep their own brand and we put it in sort of a part of our network.
Brought to you by, yeah.
Yeah, exactly.
Cool. And let's talk about value-based care for a second, because you mentioned that was kind of something that you realized was lacking with some of those earlier experiences. So are you implementing, are you taking risk? Where are you at with that?
Yeah, we're moving in that direction. And I think the changes to CMS kind of has people hesitant to move in that direction. But I'll tell you from my perspective, I get the anxiety that the folks in Florida and WellMed in California, those guys that are maxed out on their value-based, they're looking at the changes saying, this is going to provide a significant hit to my bottom line. It might be a 20% revenue hit to the top line, which is a 50% hit to the bottom line, right? It's a significant number. And, but whereas with us, we were starting in the 0.9 risk score range, right? So there's no hit that we're going to face. It might dampen the upside a little bit, but when we're not getting anything on the upside today, it's all still upside for us. And so we're still going full speed ahead, engaging in the value-based practices, moving to risk. We'll be at risk in 3 of our Medicare Advantage contracts next year, not full, 50% partial risk. We're at 75% risk level on our 25,000 MSSP lives, Track E. We're moving into that space. We're confident that we've got a model that's delivering for us in that space. We're moving the needle on all of our metrics and slowly climbing to where we need to be, implementing the changes in the physicians and the staff to make sure that things are lined up appropriately. But it's not as you're aware, since you've been in this space, it's not an overnight shift, right? It takes a little bit of time. Yep. And we've been investing slowly to get us there. So next year we'll be realizing some pretty good value out of that. And then in the future years, even more so as we continue to refine our program.
Yeah, that's awesome. Why, talk to me maybe a little bit about some of the challenges that you found, maybe that you expected or didn't expect. I mean, it is cool that you kind of you had so many different windows into different parts of the market before going on this. So it feels like you were fully informed going in, but typically there's some curveballs. I mean, it's if it was easy, everyone would do it. So what are some of the challenges with the space?
Yeah, every market's a little different, right? So, I've been in some markets and the dynamics from a system perspective or payer's perspective is all different. And so some of the challenges have been, just trying to understand which partners to align up with, which ones are going to work best with us in the space. We started with one partner. We ended up moving to another partner from a system perspective because it just felt like a better fit. So it took us a while to get there. And in the flow of that.
You mean by a system, like EHR?
Like
or what?
A hospital system. Hospital system, yeah. So we had a hospital system partner that we exited from shortly after I arrived, and we moved over to another partner. And that caused some disconnect in the way our contracts were flowing on the commercial side. So there was some issues there. Having come from a world where for myself personally, I'll just speak for myself, we've got folks on the team that didn't come from this space, but coming from a world where revenue cycle wasn't a big deal. Like at WellMed, it's fully delegated, 100% risk. 1% of their business was commercial, and it wasn't something you even talked about, right? It was full risk Medicare. Making sure that you got all of that stuff lined up. We had a little struggle trying to get that lined up for the first year or so. We've got it tight now and running tightly now. Integrating practices. So, we go out there, and there's only a couple of things we try to integrate when we bring practices on. We would say, look, we're going to move you onto our lab system and we're going to bring you into our EMR. Well, moving them onto the EMR was more of a challenge than we expected.
Never painless. Never painless.
So moving them from eClinicalWorks, most of the independent practices around here are eClinicalWorks, moving them from eClinicalWorks into Allscripts, which is our current platform on most of our employed physicians, was challenging. And so we ended up making the decision to keep a cohort on ECW and a cohort on Allscripts after a lot of trial and error there to get it to the right place. we ended up deciding just to keep 2 cohorts. And over the next 18 months or so, we're going to move to a single EMR. We're still debating on what that's going to look like. But as it stands right now, we decided to put an end to the pain and kind of keep 2 cohorts running at once.
Yeah.
And that's partly because the physicians, were getting upset about the move and things like that. So we decided just to put a hold on it for now.
Yeah, it's probably one of the toughest things is moving that kind of system, because it's so sensitive, and each one has their own backwards workflows that everyone's become so accustomed to, that trying to even straighten out the tangled workflow becomes so painful. It's like, no, but we're used to doing all these backwards things in order to send this message.
Yes.
We can't do it different.
Yeah, and they've all got customization within their workflow, right? They built it out the way they want it to be. And so not just the basic vanilla EMR, but also all the customization they created around it. All that goes away when they move, right, to another one, and they have to recreate all that. It's a painful thing.
Yeah.
So we've tried to be sensitive to that as best we can.
Yeah, no, that makes sense. Something I wanted to mention before about value-based care. I feel like even if because you were saying now with the new recalculation, you may not get all the upside as you would have maybe 2 years ago, but I think that it gives you so much more flexibility in the way that you're able to care for your patients. Like once you start taking on risk, you're able to be a lot more thoughtful and a lot more intelligent, and a lot more innovative about how to, preventive care coordination, things like that, to set these things in place. It just gives you so much more flexibility, I feel like.
Yeah, I talk about that a lot. So I speak around the area a lot, around the Southeast, with medical associations and hospital associations and things. And I talk about exactly that. One of the solutions I was on a Medical Association of Georgia legislative panel a few weeks ago, and they asked about, okay, what's the solution for rural health communities? And my solution is just exactly that, right? Let's move to risk and then take on those patients in a risk-based format that allows us then to go in and put in place all the things that need to happen to take care of those patients that you could never do. Like you're never going to get the payers to pay for Meals on Wheels, or like all the transportation that needs to happen, or home care, like all the different things that are innovative that you can do to support the patients are all fair game in a risk environment, but they're not necessarily something you get reimbursed for in a fee-for-service world. And so it does open up the aperture to do really innovative, creative things that are going to help the patients in a meaningful way.
Yeah. Brings to mind, a friend of mine started a practice years ago. He was working at, I think it was Humana. So it may have been another one of your neck of the woods. I think it was Humana. He basically borrowed money from Humana. Let's allegedly Humana. I don't know. I think it was Humana. And they and then used that to buy his first practice. Grew this thing. Went full risk. Grew it to like 2,500 docs or something like that. I don't know. Some good number. And then sold it back for an obscene amount of money that I could tell you off camera. But one of the interesting things that he said was that at one point he had a full doctor, whose entire patient caseload was 7 patients. And he said that because he was really good at his data, that's why he was so successful. He was good at running his numbers. And he realized that those 7 patients were costing him $2 million in utilization. So then all of a sudden the math starts making sense. Okay, so I'll pay this guy $350, and this doctor will take care of these 7 patients and make sure they never touch the system, But you can only start making those calculations once you're in risk.
Right. Yeah. That's right. And if you're able to share some of that back, right, you incentivize those doctors. So every time they send them to the ER or to the hospital system for an MRI versus an independent MRI, if they're getting half of that money, and you're sending them to an MRI at the hospital for $5,000 versus an MRI downtown for $500, that's $4,500. Half of that is going right out of the doctor's pocket, right? So if you can teach them how that works, it's really powerful.
Yeah, that's awesome. Wow. Well, it's really exciting to see these little corners of healthcare that are being unraveled by individuals, and it's awesome to see somebody like you with the experience that you've had all over the system at a really high level come into kind of I feel like most people try to go like higher level at a lot of these big corporations, and it's really cool to see somebody just jump in at the ground level and try to build something from the ground up. So I mean, where are you at with our doctors? First of all, where can people find you? And also, like, are doctors able to sign up right now? Or are you just over capacity? What are you looking for?
Yeah, I mean, we're always willing to talk to physicians that are interested in learning more about our group. So if you go to southeastprimarycarepartners.com, that's our website. So you can get information about our company there. and we're based out of Atlanta, so we're in the northern part of Atlanta. Our main headquarters is there, and we have clinics across Georgia into Tennessee and Alabama. So we're all around, and we're moving heavily into South Carolina. So if any physicians are in those markets where they're interested in doing something a little bit outside the box, or something that they have been considering, or they've talked to a health system, a hospital system in the past, and they're thinking that's not really a good fit for them, maybe they should talk to us or one of our teammates. I will tell you one of the things I think, so I just talked about my geography. There's a reason why my geography looks the way it does. And it's not because it's outside of an Optum non-compete. I'm way outside of that, right? It's because, I when I was at Optum, I had a chance to sit across the table from a lot of the big players that are similar to me, like the Privias of the world, the Canu Healths, the Oak Streets, the Village MDs, all of those guys, I knew them pretty well. And I sat across doing evaluations on their companies, right, from an Optum perspective in some cases. And I kind of learned what was good and bad about them. And I think one of the things that's hurt those guys, some of them over the last couple of years, is whether it's a retail clinic inside of a Walgreens or CVS or Walmart. One of the things that's hurt them is they've gone beyond their model, right? Their model was a value-based care, doctor holding the hand of the patients, taking care of them, managing them effectively, et cetera. But in the model that they deployed in the retail space, it became an urgent care center, right? So nobody's walking into Walmart or to Walgreens to have a relationship with a doctor. They're walking in there to get something done for that moment. And it kind of destroyed their model. And they built so much of that. If they would have looked at that as an urgent care model, it might have been successful, but they didn't. The other thing is, from my perspective, is they spread themselves too thin. So, whereas there's not a place that I go in my market where I can't get to myself personally in 5 hours driving, right? I can go to Charleston, which is a big group for us. I can go to Birmingham, Nashville. I'm going to be at tomorrow, Charlotte. I can get anywhere in my market within 5 hour drive, and so can my team, right? And so I think what happens with these bigger groups is they go and plant, little flags in a lot of different states, and the values and the ethos that exuded, that were able to spread itself pretty thick at the top or in that central location were strong, and they did really well there. But the minute they start to spread themselves too thin, they get down and they get B and C and D teams that are out there that don't have the same ethos, that don't have the same sort of vision and passion for what they're trying to do. And in those secondary markets, it becomes a struggle, and they're not as effective in those markets. And so we're committed to staying really thick and concentrated in our Southeast market. So you won't see Southeast Primary Care, even though Southeast Conference is spreading to Texas. You're not going to see me in Texas or Oklahoma. I'm going to stay here in, Georgia, South Carolina, Tennessee. Like, we're going to stay in this part of the Southeast. And that's by design, right? We're not going to let ourselves go too far out. There's plenty of things to do here, plenty of stuff to do right here.
Yeah. Yeah. I think that's a brilliant perspective. It's definitely a unique one for me. I haven't heard that, and I think it makes a lot of sense. So, hey, I wish you, continued awesome success. Looking forward to checking in every now and then. And Eric, thanks for spending time today. This was awesome.
Appreciate it. You as well. Take care.